Professor Sundaram sir will be presenting the shield to Venkatraman sir.
Professor Venkatraman has plenty of knowledge, but he is humbled by wisdom voice. He will be talking to us on redefining weight loss. Over to it, Professor Venkatraman.
Thank you, Professor Sundaram, Professor Rajendran. It's always a, what shall we say, home program when we do a DAISICON. And to do it in front of my mentor, not only my mentor, I think you're the mentor, Professor Seshia sir, for all of us who are associated with diabetology for the last 4 decades or 5 decades. And thank the scientific community for choosing the topic. Probably choosing the topic, they would have had some discussions, but not in choosing the speaker. Because when you go by the BMA of the speaker, there are not many contenders to address this talk. So thank you so much. In this program, I have been contracted by Lilly, thank you so much, to talk about 2 contemporary molecules which are in the therapeutic space of addressing obesity with or without diabetes. Before I dwell into the topic, another request to the chairpersons, can I take about 2 to 5 minutes extra so that the questions pertaining to the molecules I'll try to answer, and then other questions certainly I'll be happy to do it outside this program. Why talk about obesity in India? The ICMR INDIAB study has indicated that the prevalence of diabetes across the country in close to about 1,20,000 population, cross-section of the population, it was 103 million, if I remember right, for diabetes. 250 million people have general adiposity and 350 million have central adiposity. So, it's very, very relevant to talk about obesity in the Indian context. That is number 1. Then number 2, we are used to addressing obesity as one of the risk factors whenever we talk about metabolic syndrome or diabetes, like your hypertension, dyslipidemia, etc., etc. But probably now we have got the science to tell us that tentative attempts at identifying obesity and correcting are not adequate. So target-driven approach is applicable, just like you have a target for HbA1c, the blood pressure, the LDL cholesterol, the triglycerides, HDL, etc. Weight reduction is also to be a target-driven approach. That's the second point. Where does obesity contribute? Now, the main purpose of the adipose tissue is to store energy. In other words, theoretically, anybody who is weighing 90 kilos, if that person is going to consume 1,800 calories, then whatever is outside the scope of metabolism has to be stored by that adipose tissue. When the intake of calories, the nutrients, exceeds the storage capacity of the adipose tissue, then it becomes problematic. This is what we call it as dysfunctional adipose tissue. So, in fact, one of the interesting hypotheses, not necessarily in obesity, but in the diabetic population, was the twin cycle hypothesis, wherein excess nutrients, which cannot be accommodated in the adipose tissue, first gets shifted to the liver, so you have the fatty liver or the steatosis. When there is steatosis, then the function of the liver, the hepatocyte, to inhibit, that is the insulin, to inhibit gluconeogenesis comes down. The function of the liver comes down because of the fatty liver. So, in the early stages of diabetes, and probably in metabolic syndrome, there is an attempt to increase the insulin marginally. So, this extra insulin, in the face of the insulin resistance which is worsened by the fatty infiltration of the liver, is able to reasonably keep the fasting blood sugar level to a particular level. But what is the purchase? The purchase is hyperinsulinemia. When you have hyperinsulinemia and you have a good amount of milieu in the form of extra nutrients, you have increased production of VLDL. This VLDL gets converted to LDL, gives all the cholesterol to all the tissues. After all, cholesterol is required for all the tissues. Your cell membranes, your adrenal glands, the sex hormones, etc., etc. Over and above that, what happens is the excess cholesterol in the circulation, for which we know the answer in the metabolic syndrome because of insulin resistance, gets deposited in all the tissues, in your pancreas, in your heart, your kidney, skeletal muscles, so that you have the self-perpetuating cycle of hyperglycemia wherein what starts with some amount of insulin resistance and secretory defect gets worsened by the fat getting deposited in the pancreas. And also we see how the ectopic deposition of fat in the heart is associated with a lot of problems, including your heart failure and arrhythmias. And also in the kidney, how lipotoxicity can contribute to the diabetic kidney disease. Having said that, this is an hypothesis. How do you prove it? It has been proven. When you have a targeted weight reduction, say 10%, 15% weight reduction, there is debulking of the liver, the fat in all the viscera comes down, the pancreatic function improves, the insulin sensitivity improves. So the proof of the pudding is in eating. So obesity is a huge problem in diabetes. Obesity pathophysiologically contributes to the metabolic aberrations in the metabolic syndrome and diabetes mellitus. The attractive hypothesis operates through the liver, and there is fat deposition in all the tissues, and then aggressive weight reduction, which has been proved in the experimental settings, something like your 10% weight reduction, 15% weight reduction, which is possible in the research setting, is associated with improvement in insulin sensitivity, reversal of diabetes, remission of diabetes, improvement of hyperglycemia, improvement in the blood sugar level, improvement in the lipid parameters, etc., etc. Now, the third question is, obesity is prevalent. Obesity plays a pathophysiological role. But why you are talking about molecules? Why not lifestyle modification alone? All of us are aware that whenever we talked about the lifestyle modification, previously used to say 3 to 5%. Yes, 3 to 5% is achievable. Is it sustainable? That's the question that we have to think about. Yes, in a research setting, it is sustainable, but not in the clinical scenario, because once a patient reduces the diet, here I would talk about two aspects of obesity. One is the homeostatic obesity, the second is the hedonic obesity, or the hedonic pleasure of eating. In homeostatic obesity, let's say an example, a 65 kilo weighing individual takes about 1,800 calories. His metabolism adjusts in such a way, his intake and the expenditure are in such a way that we have seen in clinical practice, more or less, unless he is challenged by a catabolic disease, his weight is constant. The same patient, over a period of about 10 years, he becomes 85 kilos and eats only 1,600 or 1,500 calories, still his weight is 85 kilos, because the homeostatic mechanism is reset in such a way, it is able to adjust depending upon your intake, and this is determined at the level of the hypothalamus and the brains. Number one. Number two, I think the component of obesity which has major contribution is from the hedonic. That is the pleasure of eating. So probably the human beings or the animals who eat for the pleasure of it. I mean, we are not new to this. You have a good lunch and then we go for the dessert. All of us do it. It enjoys. Why it is so compelling is the hedonic component has a reward system. The reward is from a good neurotransmitter like dopamine from the cortex to the mesolimbic system. So that when you talk about obesity, it is purely a high structured mechanism wherein the interference should be at the level of the CNS and at the level of the gut. And attempts at weight reduction are always fraught with certain amount of, what shall we say, lack of durability, for the simple reason the hunger hormones are stimulated, and more importantly, the body adapts by reducing the expenditure. So, what might seemingly look as an adaptive mechanism by the primitive brain becomes counterproductive in the pursuit of the patient to sustain a weight loss by his own effects and also by the advice of the clinician which is being followed. So that is why we are talking about a molecule-driven approach. Then you might turn around and ask, I'll ask my patient to undergo liposuction. That will reduce about 10 or 15 kilos of weight. After all, the liposuction of a similar magnitude of weight loss is not associated with metabolic benefits. So it boils down to one approach. What is that approach? The approach is nutrient-driven restriction of calories and the weight loss is beneficial from the metabolic point of view. So here there are two choices. One is bariatric surgery. The other is the incretin-based therapy in the parenteral form. We take advantage of the fact that the GLP-1 receptors are ubiquitous, not only in the pancreas, but also in the CNS, the hypothalamus, the brainstem, the GI tract, the endothelium, etc., etc. So once you administer a pharmacological or a supraphysiological dose of a GLP-1 receptor agonist, you have reduction in the blood sugar in the diabetic. In the non-diabetic, you do have a good amount of weight loss because it has the potential to target your satiety center, the hunger center, modulate the various hormones which are associated with increased hunger. What about a co-agonist, about which we will discuss and then compare the two molecules that are in contemporary usage in the, with respect to in the context of weight loss. In the case of a co-agonist, we are used to the GLP-1 receptor agonist. We started with exenatide twice a day, then we had liraglutide once a day, then dulaglutide once a week, and then in the Indian scenario for diabetics, we had oral sema. How about this dual agonist? GLP-1 is sufficient to good amount of HbA1c reduction in weight loss. But when you talk about GIP, it has got an interesting mechanism. It improves the blood supply to the adipose tissue. One of the mechanisms worsening the insulin resistance, as I've understood, is the reduction in the blood supply because of the increase in the mass of the adipose tissue. So once you have a GIP-1 agonism, as exemplified by the tirzepatide, which is a co-agonist of GLP-1 and GIP, and then you can always call it the bias agonist because even though the molecular similarity is for GIP, it also acts on the GLP-1. The initial reduction in the blood sugar is mainly because of the GLP-1. So, improving the blood supply and then enhancing the activity of the lipoprotein lipase, modulating the fatty tissue. I think this is absolutely important. There are some missing links in this particular aspect because once you cleave the fatty acid, you have the glycerol and the fatty acid, but there is decrease in the steatohepatitis, there is decrease in the level of the adipose tissue deposit in various tissues. So modulating the fatty tissue metabolism is beneficial. In the process, the insulin resistance improves. So I wanted this good small preamble to be shared with my audience. Number one, obesity is highly prevalent in our country, contrary to what we believe. Number two, it plays a pathophysiological role so that a tentative approach at reducing maybe about 2 or 3 kilograms will not be sufficient. A target-driven approach has to be there. Number three, lifestyle modification, absolutely essential cornerstone, but when your target is aggressive, it's seldom possible to achieve it with just lifestyle modification, and more importantly, to sustain it. That comes to the question, in the context of obesity per se and diabetes, where do we position these molecules? What are the data? How early you can have the weight loss and the reduction in HbA1c? Are they durable? So with this, I'll go for a case-based discussion. Of course, this is an hypothetical case. Mrs. Veena, a 48-year-old individual, the BMI you can see, she has got obesity and dyslipidemia. This is what I was harping around. So once you attempt at a lifestyle modification, yes, there is an initial success. You can lose 3 kilos, 4 kilos, 5 kilos, but it is not sustainable. So that you always go for a seesaw pattern. You lose weight, you gain weight, you lose weight, etc. That undermines your confidence. At some stage, you give up and probably other aspects of behavioral changes do add up to it. And of course, she has got other comorbid condition which has been addressed. And she has also got OA and her functional capacity is restricted. Now, for this particular patient, there are many choices. You can advocate her, if 5% weight loss, you can give it as a target, achieve this. Or, as has been tried in many of the trials across the world, have a hypocaloric diet, 500 calorie, so that you lose about 10 kgs, or refer to bariatric surgery or a pharmacotherapy. Again, I repeat, when we talk about obesity, when I talk about dysfunctional adipose tissue, the magnitude of weight loss that has to be achieved is a target-based approach, and for this, there are only two choices, either bariatric surgery or the molecules. So, the patient can have two choices. I think we as clinicians should have the data whether the performance of one molecule in the context of obesity without diabetes is better than the other. This is what I was trying to harp on. A 5% reduction in the body weight will result in improvement of glycemia. Maybe 5 to 10% will have some effect so that some of the patients can put to remission. 10 to 15% you can have the reversal of diabetes, you can have the reversal of steatohepatitis, improvement in hypertension, dyslipidemia, starts with 5%, goes on beyond even 15%. Now, this looks very nice to hear. Yes, if you can achieve 15% weight loss, 10% weight loss, 20% weight loss, it is nice. All these endpoints are improved, OSA is improved, steatohepatitis is improved, PCOS is improved, the fertility and consumption is increased. Is it achievable? So, to look at this answer, first of all, we'll have a comparison between the two molecules, a combined dual agonist of tirzepatide with a GLP-1 receptor agonist, semaglutide. Of course, semaglutide in the subcutaneous injectable form is not available for use in India. Number one. Number two, the oral form is available, which we have been using, but here the data are with respect to subcutaneous sema. The SURMOUNT trials are there. I'm not going to go into the details about 5,000 subjects or a variable period of time I've been saying. We'll just restrict ourselves in the next 5 to 8 minutes about these two trials. First is in the context of weight reduction in non-diabetic obese individual comparing semaglutide with tirzepatide. This is head-to-head comparison, and I'm sure all of us by this time we have started using both the molecules, and you should be very familiar with the dosage initiation and then how you go about and stabilize it. So, the comparison has been with tirzepatide 10 or 15 milligram, which was the maximal tolerated dose, after the dose titration of about 20 weeks, to the further follow-up period of totally about 72 weeks, and SEMA has been started with 0.25 as per the label indication and then continued and maintained on the tolerated dose of 1.7 or 2.4 milligram. As you will see here, both the molecules are good. Both are associated with a weight loss. So, in an obese individual, non-diabetic with a BMI more than 35 as in our patient, is it relevant to talk about this molecule? The answer is given here. You start the weight reduction, you start witnessing the weight reduction right from the first month, about more than 4 to 5 kilos, and then the effect continues. Probably a semblance of plateau is reached around 1 year. So, you continue the molecule, uptitrate the dose, make the patient stay put on the dose which is tolerated by the patient, and continue. You see a weight loss which is to the tune of about 21%, 21.6 in Tirza, and with minus 15% with respect to subcutaneous SEMA of 1.7 or 2.4. Now, let us recollect the data that we saw earlier. 15% weight loss associated with reversal of diabetes, prevention of diabetes, no need to say that, reversal of steatohepatitis, improvement in hypertension, the dyslipidemia, and improvement in the insulin sensitivity, which we have not documented. So, these are the benefits accrued out of a pharmacological intervention, and the two players which are there in contemporary practice in the treatment of obesity, which have been advocated for use, which have been approved for use in the Indian scenario, they have compared them. Whenever we talk about the weight reduction, previously we used to talk about 5% weight loss because that was the maximum probably we could achieve. Now look at it. You're talking about a 25% weight reduction, and 1/3 of subjects in the tirzepatide achieved this 25% weight loss. And then, of course, SEMA was not found wanting because close to about 20% have lost more than 25%. So the metric that used, whether it is more than 10%, 15%, 20%, both the molecules have performed, and then the performance of tirzepatide, the combined dual agonist, has been better than the SEMA in the injectable form. And the waist circumference, as you will see here, from about 8 inches and 6 inches with respect to semaglutide. So more of central adiposity. I believe in the context that even the central adiposity is a form of ectopic deposition. Had the adipose tissue been functional enough, then probably the extra fat has to be accommodated in the peripheral adipose tissue rather than allow it. Probably the first step of the ectopic fat deposition is the central adipose tissue. Of course, there's not much of a consensus. I tend to believe that because we Indians have much more of central adiposity, even when the BMI is not in the obesity range. Since the GLP-1 receptors are ubiquitous, they are there in the CNS, the GI tract, we make advantage of the fact with respect to the therapeutic intervention, but when it comes to side effects, certainly there is always a purchase. The GI side effects are much, much more pronounced, as we have seen in our limited experience of both these molecules, that the GI side effects predominate. The dosage escalation is always associated in the second or third week with respect to the side effects. They are self-limiting. If they are not, then go back to the dose which they have tolerated. To give an example, in case of tirzepatide, if it is going to be 15 milligram not tolerated, if 12.5 is tolerated, go back 12.5, or from 12.5 to 10.5. Now, before I conclude, let us talk about a diabetic patient. A diabetic, about 9 years of diabetes, on submaximal doses of 2 molecules, an SGLT2 inhibitor and metformin 1.5 gram, hypertension and dyslipidemia have been addressed. His HbA1c, which was done some time back, was 9. The profile of the blood sugars, fasting and PP in this hypothetical case are given. And of course, initiating someone on a GLP receptor agonist, you always cautious to rule out a macular edema, do a retinal screening to do that. And then, what do? Again, many options are there. Yes, basal insulin, co-formulation, basal bolus, everything will do the job in him. But what are you going to do? You are going to increase the body weight. So if your twin objective is to reduce HbA1c to less than 7 or push him to 6.5 and achieve a meaningful weight loss, which will have an impact in the long-term health of the patient with respect to the metabolic parameters as well as the other mechanical problems like your obstructive sleep apnea and osteoarthritis, then the choice comes to GLP-1 receptor agonist or combined co-agonist in the form of tirzepatide. Again, like you had SURMOUNT for the non-diabetic population, of course in SURMOUNT 2 the entry was with the diabetic patients. SURPASS is for the diabetic subjects. We are not going to discuss about everything, only to say it has been compared with the basal insulins as well. We are not going to discuss about it. Since our agenda today is to compare 2 contemporary molecules which have got a robust reduction in the body weight, both in the diabetic and non-diabetic population. We are going to discuss briefly in the next 2 or 3 slides only about the SURMOUNT 2, which is SEMA in comparison with tirzepatide on top of metformin. And these are some of the data. This is from the SHIELD and ENHANCE study, wherein you will see that the point which we kept on harping right from the beginning, that as the BMI increases, the prevalence of diabetes increases. So it is imperative to reverse it. The weight reduction, chairpersons, I will finish another 2 to 3 minutes. The look ahead trial is one trial wherein whether lifestyle modification achieving a weight loss of more than 7% is associated with macrovascular endpoints. Since the purpose was not served, it was terminated. But a lot of meaningful inputs were available from this particular study, the look ahead. What were they? When you grade the weight loss in the look ahead in the post hoc analysis, the reduction in the HbA1c, the blood pressure, and the lipid parameters paralleled the reduction in the body weight. That is number 1. And then number 2, it had an impact on the CKD as well. And number 3, more important, if you look at the left uppermost panel, whatever weight loss was achieved was in the first year and it was regained in the subsequent years. That tells you, yes, lifestyle modification is good, it is associated with the results, but the sustainability is probably the one question as we have seen in the... So SURPASS 2, again, here what happened was, in tirzepatide, in this diabetic population, with HbA1c of around 8.3 and duration of about close to 9 years and BMI 34, etc., there are 3 arms. Tirzepatide 5 milligram, stabilizing dose, maintenance dose, 10 milligram, and then 15 milligram. This was compared to 1 milligram of SEMA. Of course, you might turn around and ask, after all, semaglutide 2.4 milligram was compared with Tesla 15 milligram in the previous non-diabetic population. Here it's 1 milligram, but this is the approved dose for the diabetic population. Of course, subcutaneous sema is not available for use. What I want to appreciate is, yes, all the molecules have done well. So with HbA1c of around, say 8.4 or this thing, all of them, all these molecules would have pushed these patients to less than 7 or close to about 6.5. And here, look at it, it's about 1.9 with sema. And even the smallest dose of maintenance dose of tirzepatide was associated with the, another 2 slides. As for the body weight, we talked about 15%, 20%, 25%. Now we are going to talk about HbA1c less than 5.7. See, 6.5 is the cutoff for the diabetes, 5.7 is the cutoff for pre-diabetes. Of course, they are on treatment. They are on treatment. But what I'm trying to say is, 50% of the subjects who are on 15 milligram of tirzepatide were able to achieve HbA1c less than 5.7. And then what else can you ask for? A robust weight reduction and a robust HbA1c reduction, and this trial was only for 40 weeks. So you could see the weight reduction here. Had it been continued, the plateau is not yet reached, but still you're able to have a good amount of weight reduction. And what it ultimately translates to, in a diabetic patient who is obese, who has spent about almost a decade of diabetes mellitus, if the control is not adequate, if you want to have hardcore endpoints of a reduction of HbA1c and weight, which can be defined by a composite endpoint of HbA1c less than 6.5, weight loss of more than 10% without hypoglycemia. Look at it. Tirzepatide 15 milligram was able to perform 3 times better than what sema was able to do. It's not to underscore the performance of sema, it's good, but you have a molecule with a co-agonist which is equally, if not better. And now the side effect, the same story, we are aware of it, we know how to handle this. Hypoglycemia, you do not expect with this class of molecule in the incretin-based therapy because they are not hypoglycemic agents, they are only anti-hyperglycemic. So to conclude, I'm sorry, as usual, I've taken 5 minutes. I've taken the permission from the chairpersons and we are going to look forward to the oration from our mentor. I'll conclude by saying obesity is a huge problem. It contributes to variable metabolic diseases, and targeted approach is essential, and for this we have to either indulge in bariatric surgery or a molecule-based approach, wherein you can talk about a weight reduction of 15%, 20% or 25%, and HbA1c close to about 5.7. Thank you so much.
Thank you, Dr. Venkatraman, for your extensive your deliberations on the 2 molecules with reference to the management of obesity. Since we are running behind the schedules, and let us move on to the next sessions, that is Professor Sam G. P. Moses orations. I request on behalf of the organizing committee, Professor R.S. Hariharan to chair these sessions. And of course, the speaker is none other than our mentor, guru, Professor V. Seshia, who is going to talk on decoding gestational diabetes mellitus. I call Professor Hariharan to come and occupy the dais.